Small-town nurses can't handle real trauma. That is what Dr. Caldwell said 47 minutes before everything changed. The fluorescent lights of Cedar Creek Medical in Savannah hum their mechanical rhythm over polished linoleum as Hannah Clarke moves through the night shift with the kind of practiced invisibility that comes from 3 months of being systematically unseen. Her hands are steady as she processes intake paperwork for a John Doe, unconscious, mid-30s, multiple lacerations across the chest and arms, no wallet, no identification, no phone. Just a man bleeding quietly under emergency lighting while machines track the slow decline of his vital signs. She cuts away his blood-soaked shirt with methodical precision. The antiseptic smell mingles with something metallic and copper underneath, the smell of fresh blood mixed with the particular staleness of the ER at 3 in the morning. The orderly beside her is texting someone, not paying attention. Good. That is when it happens. Something metallic clatters against the steel tray beside the patient's wrist. A challenge coin. Tarnished brass with an Army Ranger insignia so worn the details have almost faded completely, but Hannah can read it like Braille. The coin had been clutched in the unconscious man's fist so tightly that it took the pressure of his body weight against the stretcher to dislodge it. Her fingers pause for exactly half a heartbeat, the kind of pause most people miss entirely, the kind of pause that has been trained out of her in 7 different military academies across 3 continents. She reaches for the coin with the same motion she uses to reach for the next piece of gauze. Her hand closes around it. The coin disappears into her scrub pocket before the orderly even looks up from his phone. No fumbling. No hesitation. No moment where anyone could say they saw her do anything at all. Dr. Caldwell enters the trauma bay with the kind of entrance that announces itself before his body arrives. His white coat is pristine, creased at angles that suggest he irons it the night before shifts. His reputation has been built on hospital board connections rather than field hours. Everyone knows this, the way you know a suit was expensive because of how the fabric drapes rather than because someone told you. He is the type of man who believes confidence and credentials are interchangeable. "I'll be taking personal charge of this case," Caldwell says, his voice carrying the particular cadence of someone accustomed to being listened to without question. He glances at Hannah with the dismissive look he reserves for night staff, for nursing assistants, for the invisible people who keep hospitals running while doctors sleep in call rooms. "In fact, I'm betting $50 you quit within the week." Hannah continues her charting. Vitals. Timeline. Known injuries. Her pen moves in clean, practice strokes across the intake form. Small-town nurses can't handle real trauma, Caldwell continues, as if she has asked him to explain his reasoning. "You'll see something tonight that'll send you running back to whatever rural clinic you came from." The room is very quiet. The ventilator beside the John Doe's bed wheezed its mechanical rhythm, in, pause, out. In, pause, out. Steady as a metronome. The heart monitor beeped its normal rhythm. Everything stable. For now. Hannah's jaw tightens imperceptibly. Her eyes do not move from the chart. She has learned to make tightening her jaw look like concentration rather than what it actually is, muscle memory responding to an insult the way a military-trained body responds to everything, with controlled, measured restraint. What she does not do is answer. What she does not do is defend herself. What she does not do is let anything show on her face except the calm professionalism of someone who is simply doing their job. She feels the weight of the challenge coin in her scrub pocket. It is heavier than it should be. A tarnished piece of metal that means everything to someone, and she has just committed it to her possession in front of 4 witnesses who will not remember seeing her take it. The patient in the next bay is awake. Bay 4. Grizzled veteran, 70-some years old, waiting for x-rays on a fractured collarbone from a fall at his farm. He has been watching Hannah work since the moment Caldwell left the room, since the moment the fluorescent lights settled back into their steady hum and the antiseptic smell regained dominance over the copper metallic undertone. He has seen military people move before. He recognizes the precision. Hannah returns to the John Doe to suture the largest laceration, a deep cut along the left side of his chest, 5 inches long, edges ragged from whatever created the wound. She preps the area with practiced efficiency. Gauze. Antiseptic. Fresh gloves that snap as she pulls them on with a sound like quiet gunshots in the silence of the trauma bay. Her hands move with the kind of fluid precision that cannot be taught in nursing school. Field technique. Combat training. Her hands remember things her mouth will never say out loud. She threads the suture needle with hands completely steady. The first stitch is placed with the kind of accuracy that comes from having done this in conditions far worse than sterile hospital lighting, in the dark, in moving vehicles, while rounds impacted concrete around her position. She does not hesitate. She does not question her placement. She simply knows, the way her body knows how to breathe without her thinking about it. The stitches form a line so precise it looks like calligraphy. In, across, out. In, across, out. The motion is almost meditative if you do not understand what you are looking at. But the veteran in Bay 4 understands exactly what he is looking at. He watches for 3 more minutes while she completes the suture line. 8 stitches total. Perfect spacing. Perfect depth. The kind of work you only see from people who have sewn human bodies together while living in tents and bunkers and the back of hums moving through dust and chaos and things that do not have names in polite conversation. The veteran clears his throat softly. Hannah looks over. He is making eye contact with her across the space between the bays, across the gap between the machines and the fluorescent lights and the ordinary Tuesday night that is about to become something else entirely. You served, he says. Not a question. An observation. Combat medic. Hannah's hands do not stop moving. She completes the final suture, clips the excess thread, discards it into the medical waste container. Her voice, when she speaks, is quiet and level and carries no inflection that would mark it as anything other than the voice of a tired nurse at the end of a long shift. Long time ago, she says. But that is not true. And she knows it. And somewhere in the encrypted system of classified files that exist in government buildings she has not been inside in 3 years, there is a notation next to her name that reads, Active Assignment. Deep cover. Monitor subject. Report all exposure indicators. Biological agent detection protocol active. Fallujah-related suspects. Because the man lying unconscious in front of her is not a random trauma. He is an Army Ranger. He is the reason she has been placed in this hospital, in this city, in this moment, with her hand steady and her face neutral and a tarnished challenge coin burning in her scrub pocket like it weighs more than brass and metal could possibly weigh. The veteran nods slowly, recognizing the kind of truth that fits inside 3 words. He settles back into his hospital bed and returns his attention to the television mounted in the corner, to the late-night rerun that has been playing for the past hour. But his presence in Bay 4 has shifted. He is no longer just a farmer with a broken collarbone. He is another set of eyes that knows what to look for. Another person in this hospital who understands that the invisible nurse moving between the machines is not actually invisible at all. Hannah adjusts the monitor leads on the John Doe's chest and documents the suture line in his chart. Her notes are careful and precise. Laceration, left anterior chest wall, 5 centimeters, depth 0.5 centimeters, sutured 8 to 0 nylon, even spacing, hemostasis achieved. Nothing in those notes would suggest anything other than routine emergency medicine. Nothing would hint at the way her hands placed those stitches with the kind of muscle memory that only comes from 3 tours and 7 years of classified training and the kind of things that do not have official names in official documents. Dr. Caldwell walks past the bay without looking in. He is already moving on to the next crisis, the next patient, the next opportunity to assert his authority in a hospital that belongs to him the way hospitals always belong to people who have the loudest voices in boardrooms. Hannah reaches down and straightens the fall line. Her fingers brush against the challenge coin in her pocket for just a moment. She does not pull it out. She does not examine it. She just acknowledges its presence the way you acknowledge the weight of a secret, by feeling it press against you and accepting that the weight is going to be there for the duration. Her shift is 13 more hours long. The John Doe is stable. The monitors are recording. The veteran in Bay 4 has recognized her, which changes everything and nothing at the same time. She has a challenge coin that belongs to a man whose real identity she does not yet know, a man whose exposure to a biological agent in Fallujah has apparently made him important enough to warrant a 3-year assignment by someone in the Pentagon, a man who will wake up tomorrow or the next day or sometime in the next 72 hours and find himself being treated by a nurse who should not exist. The room settles back into its rhythm. In, pause, out. In, pause, out. The machines hum their mechanical lullaby. The fluorescent lights continue their endless flicker at frequencies just barely perceptible to the human eye. And Hannah Clarke, Master Chief Petty Officer, moves between the beds with the quiet grace of someone who has already survived worse than anything Savannah can offer her. She does not know yet that in 46 hours, the John Doe will crash. She does not know that Dr. Caldwell will panic at precisely the wrong moment. She does not know that her hands will move on their own, that muscle memory will override protocol, that she will save a life in a way that no ordinary nurse could possibly save it. She does not know yet that everything is about to change. The cafeteria at Cedar Creek Medical hummed with the soft percussion of forks on plastic trays, the fluorescent lights casting everything in a sickly beige. Hannah Clarke sat alone at a corner table, her scrub still damp from a 16-hour shift, a Salisbury steak growing cold in front of her. She wasn't eating. She was listening. 3 tables over, 2 residents were discussing a trauma admission. 2 tables in the opposite direction, a phlebotomist complained about her weekend. The soldiers' training never turned off. Situational awareness was breathing. The first sign was the coffee cup held deliberately loose. She saw Dr. Caldwell before he reached her table, saw the way his grip on the ceramic mug had gone slack, the angle of his arm suggesting preparation rather than accident. The fluorescent lights caught the edge of his jaw as he moved through the cafeteria, his white coat trailing behind him like a cape. He was walking slow. Theatrical. Making sure people watched. "Excuse me, sweetheart," he said loud enough for the 3 nearest tables to hear. His elbow jerked outward in what any observer would register as unintentional, natural, clumsy. The coffee cup tilted. Physics took over. The tray didn't stand a chance. Salisbury steak and green beans exploded across the tile in a wet, violent scatter. Iced tea cascaded across the edge of the table like a small brown waterfall, soaking into Hannah's scrub pants at the thigh. The ice rattled and settled. A fork clattered twice on the floor before going still. The room went dead silent. Hannah's hands remained flat on the table, fingers spread, utterly motionless. Her jaw tightened, not visibly, just a microscopic tension in the angle of her mandible that someone would need military training to notice. Her eyes did not move from the spreading stain on her lap. For 3 seconds, she breathed in through her nose and out through her mouth, each breath measured like a metronome. This was the test. This was the moment where small-town nurses quit. "Oh, how clumsy of me," Caldwell said, his voice dripping with false contrition. He set the empty coffee cup down on her table with deliberate care, as if he hadn't just weaponized it. "But I suppose night shift reflexes aren't what they used to be. The body does decline after a certain age, doesn't it?" He smiled, not a warm smile, not even a cruel smile. A clinical smile. The smile of a man who had practiced it in the mirror. Hannah rose without responding. Without looking at him. She walked to the napkin dispenser with the precision of someone moving through a minefield, pulled out a stack of paper towels, and knelt to clean the mess. The Salisbury steak was still warm, its grease making the tile slippery. She worked methodically, cataloguing every witness without lifting her eyes. The resident at table 3 who had stopped mid-bite. The phlebotomist who was pretending not to watch. The housekeeping supervisor in the corner who had gone very still. She catalogued Caldwell's shoes, Johnson and Murphy loafers, expensive, recently polished. She catalogued the exact pitch of his breathing. She catalogued the angle of his smile. This job wasn't just a job. This job was her mission, and losing her temper meant losing her cover. Losing her cover meant losing access to the John Doe in Bay 7, the Army Ranger who had been exposed to something in Fallujah that the Pentagon still wouldn't name in writing. 3 years of building this identity, 3 years of night shifts and careful credentials and keeping her hand steady while people like Caldwell tested her fracture points, it all came down to the next 5 seconds. She stood, deposited the soiled napkins in the waste bin, and returned to her table without a word. Her face showed nothing. Absolutely nothing. The kind of nothing that takes more strength than anger. "You're a trooper," Caldwell called after her, loud enough for everyone to hear. "Really, your composure under pressure is something else. I'd hate to see it tested any further." Hannah sat back down. She took a bite of her steak. It was cold now, the texture all wrong, but she chewed it anyway with mechanical precision. Around her, the cafeteria resumed its normal sounds, conversations restarted, forks clicked against plastic again. But everyone had seen it. Everyone had registered that Dr. Caldwell, the ER director, had deliberately spilled coffee on a night shift nurse and walked away without apologizing. That was stage 1 of his assault. Social attack. Established dominance through public humiliation. The next morning, she saw stage 2. The day shift transition team was gathered at the nursing station when Caldwell arrived for morning rounds, 7 nurses, a resident, 2 medical students, a respiratory therapist. Hannah was entering the previous night's vitals into the computer, her fingers moving across the keyboard with the same steady precision she'd used to stitch wounds in field conditions. She didn't look up when Caldwell walked past. He dropped a patient chart at her feet like it was garbage. The sound was sharp. A flat plastic folder striking tile. Everyone stopped. Everyone turned. "Pick that up, sweetheart," Caldwell said, his voice pleasant as spring rain. "Unless field dressing training didn't cover basic object retrieval." A resident snickered, a high-pitched, nervous sound. The kind of laugh that comes from relief that the humiliation isn't directed at you. Hannah could smell the hospital coffee on his breath, could hear the slight tremor in his voice that indicated arousal. He was enjoying this. She bent. She retrieved the chart. She handed it back to him without a word, without a glance, her face a perfect mask of professional courtesy. But as she straightened, she became aware of eyes on her, different eyes than the others. An older set, weathered, carrying weight. The veteran in Bay 4 was watching her. He was a grizzled figure, forearms tattooed with faded symbols of units long dissolved, waiting for X-ray clearance to go home. During Hannah's 2 a.m. rounds, she had checked his vitals, and he had watched her hands move through the motions with the intensity of someone reading scripture. She had written down his blood pressure without meeting his gaze, professional distance, nothing to indicate that she had recognized the Vietnam-era tattoo on his chest, the hospital discharge papers dated 1973. Nothing to indicate that she knew exactly what his scars meant. But now he was watching her pick up a chart from the floor and hand it back to the man who had just humiliated her, and his eyes held a question that went deeper than the surface. Later that afternoon, during the quiet hour between lunch and shift change, Caldwell made his move into stage 2. Strategic. Competent. Institutional. He called an unscheduled staff meeting in the break room and announced that he was implementing a comprehensive competency review for the night nursing staff, effective immediately. "Standards have been slipping," he said, his voice taking on the tone of someone deeply concerned about quality care. "I've had several questions about the training protocols we're using." Specifically, he paused, and Hannah felt the weight of his attention like a physical force, where the credentials from certain less traditional programs meet Cedar Creek standards. Hannah continued entering data into the shared laptop. Her fingers did not pause. Her face remained neutral. But she knew what he was doing. She had already received the memo, slipped into her mailbox between shift change, the paper crisp and official, printed on hospital letterhead. Effective immediately, the memo stated, her assignment to the John Doe patient in Bay 7 was being reassigned to a day shift RN to ensure appropriate skill matching with patient acuity. Appropriate skill matching. Translation, you're off the patient you came here to monitor. She learned from the grapevine that Caldwell had already made calls. Johns Hopkins. Board members. A private investigator from his medical school days, the kind of investigator used to scrub backgrounds and find inconsistencies. Hannah's cover identity, 3 years in construction, credentials from a small nursing program in Northern Virginia that existed on paper only, would hold up to most scrutiny. The Pentagon had built it with a kind of precision normally reserved for nuclear launch codes. But sustained institutional pressure, a determined investigation, enough scrutiny from enough directions? The mask could crack. That was stage 2. Not louder bullying. Competent institutional sabotage. The grizzled veteran from Bay 4 was discharged that evening. As Hannah signed off on his paperwork, he paused at the nursing station and looked at her directly for the first time. His eyes were the grey-blue of Atlantic storm clouds, and they held decades of combat and survival etched into every line around them. "You served," he said quietly. It wasn't a question. Combat medic. Hannah's hands continued their work, documenting his discharge vitals, entering the final notes into his chart. Her fingers did not hesitate. "Nursing school," she said flatly, without meeting his gaze. It was the answer she had rehearsed for any observer who might recognize the signature of her technique, the economy of motion, the absence of wasted energy, the way she could read a patient's deterioration in the space between heartbeats. "I've seen enough field stitches to know the difference," the veteran said. He was still standing there, not moving, not leaving. "You learned that under fire." Hannah completed the final line in his chart, printed the discharge summary, and signed it with careful, unremarkable penmanship. Only then did she look up at him, and her eyes held something that had no name in civilian medicine. "Safe travels," she said. The veteran studied her for 3 more seconds. Then he nodded, one small dip of his chin, the kind of acknowledgement that passes between people who have walked through fire together. He left without another word, his discharge papers in his weathered hands. But he had become a witness. Someone in the hospital now knew, not with certainty, but with the kind of bone-deep recognition that comes from surviving impossible circumstances, that Hannah Clarke was not a small-town nurse with a nervous temperament and steady hands. Someone knew there was more underneath the surface. At 4 a.m., during the quiet hour when the hospital breathed like a sleeping giant, Hannah sat in her car in the parking garage. The structure was all brutal concrete and flickering fluorescent panels, the air carrying the metallic taste of rain. She held the tarnished challenge coin between her fingers, turning it slowly in the overhead light filtering through the windshield. The coin was old, weathered, the kind of object that carried weight beyond its physical mass. She had no right to it. She had pocketed it before Dr. Caldwell could log it as evidence, before the hospital's possession chain could begin, and now it was the only proof that the John Doe in Bay 7 was exactly who she believed him to be. She had been ordered to monitor him. Biological exposure indicators. 3 years building this identity had been for this specific assignment, this specific patient, this specific threat that lived in classified briefings and compartmented intelligence networks. Now Caldwell had cut her access to his room. A memo. A reassignment. An institutional knife inserted so smoothly that no one watching would see it as anything but routine procedure. But it was a knife nonetheless. She was forbidden from entering his room effective immediately. She was off the case. She was out. The John Doe's vitals had been unstable for 6 hours. The monitors in Bay 7 were showing something the medical team hadn't identified yet, something Hannah had been trained to spot in Fallujah, in Sanjan Valley, in the kind of hot medical emergencies that left lasting marks on the nervous system. Something that required monitoring by someone who knew what to look for. Someone like her. And she was sitting in a parking garage, turning a tarnished coin between her fingers, weighing the cost of mission failure against the cost of breaking cover. The rain began to fall, hammering the windshield like applause, and Hannah Clarke, a Master Chief Petty Officer, decorated combat medic, officer in a branch of service that didn't officially exist, closed her eyes and made a choice that would change everything. The rain stopped. Hannah sat in her car in the Cedar Creek Medical parking garage, 3rd level, concrete walls echoing the sound of her breathing. The challenge coin rested in her palm, tarnished silver with the insignia of the 75th Ranger Regiment worn nearly smooth from 18 years of field use. She'd stolen it from a dying man because letting it get logged into the hospital system would trigger recognition protocols she couldn't afford. She'd known that going in. What she hadn't accounted for was the man in Bay 4. She was back on shift at 10 p.m., and the hospital felt different. The fluorescent lights buzzed their usual frequency, but the air pressure had changed somehow, the way it shifts before a storm breaks. Hannah moved through the corridor in her scrubs, mask dangling at her neck, her shoes making no sound on the tile because she'd learned decades ago that silence was a tactical advantage. Cedar Creek Medical was quiet at this hour. The day shift had cleared out, leaving only the graveyard crew and the stragglers waiting for discharge. The John Doe was still unconscious in Bay 2, his chest wall wrapped in surgical dressings, his monitor keeping time like a metronome counting down. Hannah pulled the privacy curtain closed and began her rounds with the precision of someone who'd done this in combat zones on 3 continents. Vitals first. Heart rate 78, blood pressure 128/76, oxygen saturation 97% on 4 liters. Normal. Textbook recovery from blunt trauma. She unwrapped the chest laceration, a 7-centimeter gash along the left anterior chest wall that she'd sutured with interrupted 4-0 nylon exactly 3 hours ago. The stitches were clean. No drainage. No sign of infection. No sign of anything wrong. But Hannah had learned in Fallujah that the things that kill you are rarely the ones you see coming. She was changing the dressing at 2 a.m. when the monitor spiked. Not dramatically. Nothing catastrophic. Just a small climb in the heart rate, 80, 82, 85. His breathing accelerated. Blood pressure ticked upward, 132, 135, 138. Hannah froze with the sterile gauze in her hand, watching the waveform like she was reading text in a language only she understood. The changes were subtle. Textbook vital sign drift. A normal person would attribute it to sleep disturbance or pain returning as the anesthesia wore off. A normal person wouldn't be watching closely enough to notice that his respiratory effort was increasing, he was working harder to breathe for no apparent reason. Hannah set down the dressing materials and placed her palm against his chest, feeling through the bandages for the answer her instruments were already giving her. The heart was working too hard. Pushing against something. The sensation was like listening to an engine that was knocking, subtle but unmistakable once you knew what to listen for. She didn't move. Didn't call anyone. Didn't break protocol or draw attention. She simply replaced the dressing, noted the vital sign changes in the chart with her typical meticulous documentation, patient exhibiting mild tachycardia and tachypnea, likely post-operative response to pain stimulus. Continue monitoring, and made a note to herself in a language nobody else would read. He was deteriorating. Something was happening inside that chest that shouldn't be, and it was happening slowly, the way the worst crises always did. The veteran in Bay 4 was still awake when she finished. He'd been waiting for discharge papers since noon, a grizzled man with a tattoo of the 82nd Airborne on his right shoulder and a prosthetic left leg leaning against the wall beside his bed. She'd seen him watching her the previous night, his eyes tracking her movements with an intensity that suggested he was reading her the way she read vital signs. "You're a long way from where you should be, soldier," he said quietly. His name was Mitchell. First name Clayton. Former sergeant major, discharged on medical retirement, waiting for someone to drive him home. He'd been at Cedar Creek for a knee replacement surgery that had gone fine, and everything after that had just been bureaucratic delays. Hannah paused in the doorway. Her training said keep moving. Her cover said say nothing. But something in the way he was looking at her, with the kind of recognition that only came from having held a bleeding Marine in your arms, made her stop. "Those hands," Mitchell said. "That suture technique. You don't learn that in a civilian nursing program. You learn that with your fingers on a chest in a transport vehicle doing 90 miles per hour toward forward operating base Shank." He tilted his head slightly. "Combat medic? Or something higher?" Hannah's jaw tightened once, then released. She didn't answer. Didn't nod. Didn't confirm. She simply held his gaze for exactly 3 seconds, then continued down the corridor. But Mitchell had seen what he needed to see. The next 36 hours were a study in deterioration watching. Hannah monitored the John Doe's vitals every 2 hours, then every hour, then every time he shifted position. His heart rate climbed incrementally, 88, 92, 96, 101. His blood pressure began a slow ascent that mimicked the slope of a long runway, 135, 138, 142, 145. His respiratory rate climbed. His oxygen saturation, once rock solid at 97%, began to drift south, 96, 95, 94. All of it was happening slowly enough that nobody else seemed to notice. All of it was happening fast enough that Hannah understood exactly what was occurring inside his chest. Cardiac tamponade. The sac around the heart filling with blood from an undetected penetrating injury. Pressure building. The heart being compressed. The pump losing its stroke volume. The body compensating with tachycardia and increased respirations, a desperate attempt to maintain circulation by pushing harder on a damaged system. She reported the changes to the resident on call, a second-year named Yuki Park, who glanced at the numbers and said, "Post-operative drift. He's fine. Get some rest." She reported them to the night shift supervisor, who made a note and said nothing else. She reported them to Dr. Caldwell when he made his morning rounds, and he looked at the chart, frowned slightly, and said, "We'll monitor. Call cardiology for a consult if his SATs keep dropping." That was stage 4 of Caldwell's assault. Not the crude violence of throwing trays or charts. Not the public humiliation of the cafeteria. This was something worse. This was strategic neutralization. He had formally instructed his residents to defer all patient decisions to cardiology consultation. He had created a paper trail documenting normal vital sign variation. He had built a system where Hannah's warnings would be buried under protocols, where her expertise would be ignored because she was just a nurse with 3 months at Cedar Creek Medical, and he was the emergency department director with Johns Hopkins credentials and a network of hospital board connections stretching across 3 states. By the 4th night, the John Doe's heart rate was 126 at rest. His blood pressure had climbed to 158/92, elevated but not alarming to anyone who wasn't watching the trajectory. His respiratory rate was 28, and he was working hard for every breath, the way drowning men work hard for air. His oxygen saturation on 4 liters was 91% and sliding. The cardiology consult hadn't been called. The cardiologist assigned to the hospital didn't have availability until the next afternoon. Hannah was in Bay 2 at 11:38 p.m. when the monitor alarm sounded. Not a warning beep. The full code alarm, the sound that makes every medical professional in a 100-yard radius turn toward the speaker. The John Doe's heart rate had spiked to 148. His blood pressure was 94/52 and falling. His oxygen saturation was 88 and dropping. His skin was turning the color of wet concrete. His pupils were dilating. He was crashing. Caldwell arrived within 90 seconds, followed by 2 residents and a nursing assistant. He was moving with the precise confidence of a man who'd never had to stitch a wound under fire, never had to make treatment decisions with rounds incoming, never had to watch someone die because the right equipment wasn't available. He was moving with the confidence of someone who had studied this exact scenario in a textbook. He reached for the ultrasound machine. His hands were steady but uncertain. He positioned the probe against the patient's chest, searching for the right angle, the right view. Ultrasound is like reading an X-ray made of sound waves. You have to know what you're looking for, have to understand the architecture of the body well enough to interpret the image you're seeing. Caldwell had learned it in a simulation lab at Johns Hopkins, not in a field hospital in San Juan Valley where the only ultrasound machine was powered by a generator that sounded like a helicopter. "Pericardial effusion," he announced. The 2 residents leaned in, recording everything for the chart, for the documentation, for the institutional record. Significant fluid collection around the heart. "We'll need to consult cardiology immediately and prepare for possible pericardiocentesis if his hemodynamics continue to deteriorate." The room went exactly as quiet as it needed to. Hannah was in the doorway, watching Caldwell position the probe again, searching for a measurement, trying to determine if the fluid collection was truly significant or just a normal post-operative variance. His hands moved with academic precision. His mind was running through the differential diagnosis. His ego was fully engaged in being the smartest person in the room. What he couldn't see was the patient's heart rate climbing to 152. What he couldn't see was the blood pressure falling to 88/48. What he couldn't see was the oxygen saturation at 84% and the patient's skin taking on the pale gray color that meant his body had minutes before his organs began to fail. What he couldn't see was that morning was too late. What he couldn't see was that the cardiology consult he'd been too important to place was too late. What he couldn't see was that the textbook solution he'd learned in a simulation lab was too late. What he couldn't see was the veteran in a wheelchair rolling silently into the room behind Hannah. "That doctor's going to kill him," Mitchell said quietly. Not a question. A statement of fact delivered with the certainty of someone who'd watched men die from wrong calls in the field. "And you're going to let him because of whatever you're hiding." Hannah's hands gripped the doorframe so hard her knuckles went white. 3 years. 3 years of deep cover, of pretending to be small-town nursing staff, of accepting insults from a man who'd built his career on board connections instead of competence. 3 years of monitoring this patient, an Army Ranger exposed to a biological agent in Fallujah that the Pentagon was still investigating. 3 years of a mission that would be compromised the moment she revealed what she actually knew. The John Doe's monitor alarm sounded again. A steady shriek. Caldwell still hadn't called for the crash cart. He was still searching for the right ultrasound view, still trying to definitively diagnose something that was obvious to anyone who understood what they were looking at. The patient's oxygen saturation hit 79%. His heart rate was erratic now, 123 to 134 to 118 to 142. The rhythm was destabilizing. "I don't know who you are," Mitchell said, and there was something in his voice like a prayer, like a command, like a reminder of every oath she'd taken. "But I know what you are. And I know you don't leave people behind." The patient's monitor spiked again, a sudden electrical chaos that meant the heart was losing its organized rhythm. The monitor showed atrial fibrillation converting to ventricular fibrillation. He was 2 minutes away from cardiac arrest. Maybe 1 minute. Hannah's jaw clenched once, then released. She stepped through the doorway. She moved past Caldwell without asking permission. She moved past the residents without breaking pace. She grabbed the spinal needle from the crash cart, 14 gauge, sterile, exactly what she needed. Her hands moved like they'd done this before because they had. In Fallujah. In a forward operating base during a sandstorm. In a transport vehicle moving toward base while a Marine bled out beside her. She placed her hand on the patient's chest. Found the anatomical landmarks the way muscle memory takes over when conscious thought becomes a liability. Second intercostal space, mid-clavicular line, just below the clavicle. She didn't hesitate. Didn't ask. Didn't announce what she was doing. She drove the needle through skin and ribs and pericardium. And she listened for the sound that meant she'd done it right. The hiss of air escaping. Blood flowing backward through the needle as the pressure inside that sac released. The patient's oxygen saturation immediately began to climb, 80, 82, 85. His heart rate stabilized at 112. His blood pressure climbed back to 96/56. The monitor showed his rhythm organizing, normalizing, returning to sinus rhythm. Caldwell stood motionless with the ultrasound probe still in his hand, his face transforming through several colors in rapid succession, red, then white, then red again. "Get him to cardiothoracic surgery," Hannah said quietly. Her voice had changed. The deferential tone was gone. The careful small-town nurse accent had vanished. What remained was the voice of someone who'd given orders in combat zones and watched them executed without question. "Stat. Now. Tell them it's a hemopericardium from a penetrating fragment. They have 40 minutes to get him into the OR before his cardiac output fails completely. And someone page cardiology and tell them the consult they were too busy to place is actually urgent. Nobody moved. Nobody questioned. Hannah moved past Caldwell without asking permission, her hand already reaching for the crash cart. The monitor's rhythm had flatlined into a thin green line, the alarm a constant shriek that cleared the room like a siren. "Nurse Clarke, I ordered you to stand down," Caldwell said, but his voice was thin, already losing authority as the patient's oxygen saturation plummeted toward 30. She didn't answer. She was already moving, her body operating on something deeper than conscious thought, muscle memory forged over 15 years and 6 combat deployments, in field tents and burning vehicles and medevac helicopters where the difference between a 75-second procedure and a 90-second procedure meant the difference between a living soldier and a body bag. Her hands reached for a spinal needle without her eyes leaving the patient's chest, her fingers moving with the fluid precision of apex predators, each motion economical and exact. She prepped the needle with betadine using her non-dominant hand while her dominant hand palpated the intercostal space between the patient's 4th and 5th ribs, her fingertips reading the anatomy like braille. "What are you doing?" Caldwell demanded, his face already flushing the color of infected tissue. "You don't have authority to." "Pericardiocentesis," Hannah said flatly, the word clipped and clinical. Her voice had dropped an octave. The timid small-town nurse was gone. In her place was someone else entirely, someone who had held a tourniquet on a Marine's leg while artillery shook the ground, someone who had intubated a 14-year-old interpreter in the back of a Humvee with nothing but a flashlight and a pediatric tube she'd stolen from a field hospital 3 days prior. She positioned the needle at a 45-degree angle, aiming toward the left shoulder, angling beneath the xiphoid process where the anatomy allowed access to the pericardial sac without lacerating the lung or the anterior coronary artery. The residents watched her hands like they were watching surgery performed by a ghost. One of them, the tall one who'd laughed when Caldwell knocked her tray to the floor, actually stepped back, clearing space, understanding instinctively that Hannah Clarke was no longer in the same category as people who asked permission. She drove the needle through muscle and fascia and pericardium with a single controlled motion. No hesitation. No tremor. No breath. The needle slid home and her left hand was already drawing back the plunger before her right hand finished advancing it, an action so synchronized it looked choreographed, and it was, in a way, choreographed across 100 field saves in places where mistakes killed people whose names she still remembered. Dark blood filled the syringe. Not arterial red. Not capillary ooze. The dark maroon of decompensated hemopericardium, the blood that had been compressing the patient's heart into a ventricle that couldn't fill, couldn't pump, couldn't perfuse. The pericardial sac had been a tourniquet around his heart. The monitor beeped once. Twice. The green line stuttered back into rhythm, not perfect, not stable yet, but alive. Beating. Perfusing. The numbers climbed, 72. 84. 92. Hannah didn't move. Her hands were still on the needle, making fine adjustments, ensuring she'd drawn enough to decompress the tamponade without creating a pneumopericardium that would require a chest tube and thoracotomy she wasn't qualified to perform. This was the hairline fracture between saving a life and creating a different emergency, and her hands knew the difference. 45 seconds from needle entry to sinus rhythm. The room had stopped breathing. Caldwell's face went white first, the authentic white of shock, the color of someone watching their narrative collapse in real time. Then it went red, the red of fury mixed with something worse, the red of a man realizing he'd just handed his enemy a weapon. Hannah withdrew the needle, disposed of it into the sharps container with the same mechanical precision, and stepped back from the bed. She didn't look at Caldwell. She didn't need to. She could feel him calculating, recalibrating, understanding that he'd just watched a procedure that required not just medical knowledge but the kind of tactical calm that came from having already survived the worst. One of the residents exhaled. Someone whispered, "How did she?" and didn't finish because the answer was already crystallizing in the room's electric silence. A veteran waiting for x-rays in the hallway, the grizzled man with the Semper Fi tattoo who'd watched her suture the John Doe's chest wound days before, nodded once, slow and deliberate, the kind of nod that carried entire conversations in military culture. He'd already known. Hannah had just confirmed it. Caldwell's jaw clenched so hard the tendons in his neck stood out like rope. "You just ended your career," he said, his voice shaking with something that might have been rage or might have been fear. "You performed a procedure without authorization. Above your scope. Above your certification. You endangered this patient," but even as the words came out, both of them knew how that sentence would be received. A man who'd been standing 3 feet away watching her save a flatline patient that he'd missed entirely, now claiming she'd endangered him. The fluorescent lights hummed their constant electric song. The monitor beeped its steady rhythm. 45 seconds of competence had just become Hannah's death warrant. Within an hour, Caldwell had made 3 phone calls, the hospital board chairman, his mentor at Johns Hopkins Medical Center, and a private investigator he'd roomed within medical school, a man who specialized in credentialing investigations and professional liability cases. The narrative was already constructed before Hannah finished charting, unlicensed nurse practicing above her scope. Cardiac tamponade management performed without physician oversight. Direct violation of state nursing practice regulations. Endangerment of patient through unauthorized intervention. The words were technically accurate. They were also completely missing the context that the patient was dead without the intervention and alive because of it, but context rarely survived contact with institutional procedure. Hannah's security badge was deactivated by 11 a.m. The hospital security director, a woman named Morris who'd seemed kind during orientation, called her into a small office and said, "I'm sorry. This is above my pay grade, but you're suspended pending investigation. Effective immediately. Don't come back until legal clears it." By noon, Hannah wasn't allowed in the John Doe's room anymore. By 2 o'clock, she'd been escorted from the building by a security guard who wouldn't meet her eyes. The tarnished challenge coin was in her pocket. It had been there the entire time, a weight against her ribs like a heartbeat, the metal worn smooth by hands that had held it through firefights and funerals and 14-hour surgeries in combat support hospitals. She'd kept it there for 3 months. She'd kept her entire identity there, encoded in that single piece of oxidized metal, waiting for the moment when extraction became inevitable and her cover was no longer worth the price of staying hidden. 3 years. 3 years of night shifts and small-town dinners and Caldwell's casual cruelty, because the John Doe, the ranger from Fallujah, the one with the biological exposure from a classified op no one was supposed to know about, had needed someone on the inside. Someone who could recognize a hemorrhage in the dark. Someone whose hands wouldn't shake when a patient decompensated. Someone whose primary mission was keeping him alive long enough for the Pentagon to figure out what they'd exposed him to and what they needed to do about it. Hannah sat alone in an empty diner at 3 a.m., the kind of place where the coffee was strong enough to remove rust and the pie had been made the same way since 1987. The cup in front of her was full and going cold. She hadn't slept in 28 hours. The challenge coin sat on the table beside the napkin dispenser, catching the weak light of the corner booth, its surface catching shadows like it was breathing. Her phone was silent. No texts. No calls. The Pentagon communications protocol required her to wait for them to contact her. Extraction would come as an order, not a request, and only when they decided her cover was irretrievably compromised. She'd just saved the patient they'd sent her to protect, which meant her mission parameters were technically complete. She'd also just revealed competence levels that no civilian nurse could maintain, which meant her identity was a live wire waiting to spark. Those 2 facts were now in direct conflict with each other, and Hannah Clarke sat in a diner in Savannah at 3:17 in the morning, waiting for the Pentagon to decide whether she'd be celebrated or disappeared. The window reflected her face back at her, a sharp-edged, composed, the face of someone who'd made peace with having nothing left to lose because she'd already lost it the moment she'd pocketed a challenge coin and agreed to become someone else. The phone call started at 4:44 a.m. Dr. Caldwell sat in the physician's lounge, his hand still trembling from the OR, the image of Hannah Clarke performing a pericardiocentesis in 45 seconds burning behind his eyelids like a brand. His face had gone white, then red, then a shade of gray that matched the fluorescent hospital lighting. Within an hour, he'd made 3 calls. The board chairman at Johns Hopkins, his mentor, the man who'd given him his first faculty position. A private investigator from medical school, someone who owed him favors from a messy divorce. And Cedar Creek Medical's board chairman, a man whose brother-in-law controlled half the city council. The narrative was already constructed in his mind, polished and ready. An unlicensed nurse. A procedure outside her scope. A patient at risk. Protocol violations. He positioned himself as the guardian of patient safety, the defender of medical standards, the one brave enough to blow the whistle on a dangerous operator who'd infiltrated the ER posing as a nurse. The Johns Hopkins mentor made calls to the state medical board. The private investigator began pulling employment records. The board chairman authorized an immediate investigation. By 6:38 a.m., the machinery was in motion, institutional power grinding down to crush a woman he didn't understand and had vastly underestimated. Hannah didn't see her security badge when she arrived for her shift at 7 a.m. It wasn't at the security desk. It wasn't at the locker room. The security officer, a Navy veteran named Martinez with gray at his temples, handed her a printed sheet instead. "Ms. Clarke, you've been placed on administrative suspension pending investigation into credentialing violations and scope of practice concerns. You're not to access patient records or patient rooms. Effective immediately." She read the sheet. Her hands were steady. Her breathing was steady. But the question in her mind was not steady. 3 years of deep cover. 3 years of medical school, nursing boards, certifications, background checks that held up because they were designed to hold up. A classified mission monitoring an Army Ranger exposed to a biological agent in Fallujah. And one doctor who'd decided she was a threat to his authority had just deactivated her access to the patient she'd been sent to protect. The John Doe was in room for 12. She could see his door from the main hallway but couldn't enter it. The security badge hung in her locker. The mission was gone. The cover was compromised. And 3 years of waiting, of accepting insults, of letting Caldwell destroy her in public, had been wasted on a moment of competence she'd been trained her entire career to deliver. Hannah drove to the Magnolia Diner on Victory Drive and ordered coffee at 3 a.m., watching it grow cold in the cup in front of her. The window reflected her face back at her, a sharp-edged, composed, the face of someone who'd made peace with having nothing left to lose because she'd already lost it the moment she'd pocketed that challenge coin and agreed to become someone else. She'd saved a man's life. She'd exposed her training. And she'd done it because the alternative was letting him die on her watch, which meant her mission parameters could go to hell because some things were worth more than operational security. Caldwell would succeed. The board would accept the investigation. Cedar Creek Medical would agree to enhanced credentialing protocols, Hannah's idea, ironically, twisted into the weapon that destroyed her. She'd be quietly dismissed, her references questioned, her reputation methodically dismantled by a man who'd spent his entire career building relationships with people who owed him favors. The challenge coin was still in her pocket. The mission was over. The Pentagon would extract her, debrief her, and assign her somewhere else, and Caldwell would go back to his rounds, victorious. That was what Hannah thought at 3:44 a.m., watching her cold coffee reflect the diner's fluorescent lights like stagnant water. What happened next didn't just change her mind. It changed everything. The hospital lobby at 8 a.m. was packed with news crews. Dr. Caldwell stood at a podium in a pressed suit, his face composed, his tone grave as he announced new credentialing protocols for Cedar Creek Medical, a measure designed to protect patients from unsafe practitioners, from nurses who stepped outside their scope, from the dangerous assumption that anyone with the right paperwork could practice medicine. The board chairman stood beside him, nodding approvingly. Several staff members were scattered throughout the crowd, uncertain why they'd been summoned. The news anchor was mid-question about implementation timelines when the breaking news alert cut across every screen in the lobby. "We're getting word from the Department of Defense that a decorated Master Chief Petty Officer, presumed killed in a classified operation 7 years ago, has been identified alive and working in an undisclosed location. The Pentagon has just released a statement confirming the identification." Caldwell's voice stopped mid-sentence. The lobby fell absolutely silent. The kind of silence that happens when reality fractures in front of you, before your mind catches up. A soldier, young, maybe 24, with the bearing of someone who'd been trained to stand at attention, stepped forward from the crowd. Not a journalist. Not hospital staff. Someone with a military haircut and a set to his shoulders that made the air pressure change. He looked directly at Hannah, who'd stepped into the back of the lobby, wearing civilian clothes, her badge in her pocket. "Ironstone 6, he said quietly. The elderly security guard, Martinez, the Navy veteran, came to attention. His hand rose to his chest. His voice carried across the entire lobby, military precise and bone-deep certain, Master Chief Petty Officer Hannah Clarke. Silver Star. 2 Bronze Stars. Navy Cross. The doors at the rear of the lobby opened. Not security. Not hospital administration. A 2-star general, ribbons on his chest like a flag, his service record folder open in his hands, his eyes the color of corroded steel. He began reading aloud. Master Chief Petty Officer Hannah Marie Clarke. 23 years of active service. Stationed with SEAL Team 3, Charlie Platoon. 3 combat tours in Fallujah and Anbar Province. Wounded in action twice. Awarded the Navy Cross for heroic action under fire. Classified mission assignments, 2019 to present, status active. Caldwell's face had gone white. Not red. Not grey. The specific white of a man watching his carefully constructed narrative collapse in real time, on camera, in front of rolling news feeds and the hospital board and every staff member who'd heard him call Hannah small town and sweetheart and just a nurse. The general continued. I understand you've been conducting an investigation into Master Chief Clarke's credentials. Caldwell's mouth opened. Closed. There were protocol violations. She performed a procedure outside her stated scope and patient safety. She performed a procedure, the general interrupted, his voice like a tank idling in a garage, that you failed to perform, using skills acquired saving lives in combat zones while you were building board connections. Pentagon security has reviewed all 16 of your allegations. Every single one. Would you like to explain why you've spent the past 72 hours attempting to destroy the career of a decorated combat veteran conducting a classified mission at this facility? The room didn't just go silent. The room held its breath. Cameras were rolling. The board chairman stood frozen, understanding only now that he'd been maneuvered into backing a complaint against someone the Pentagon was actively protecting. Martinez saluted Hannah. One precise, bone-deep movement. Hand to forehead. The gesture of a subordinate recognizing superior rank. The young soldier behind him did the same. The general turned to the board chairman. Effective immediately, Dr. Caldwell's position as ER director is terminated. Security will escort him out. It wasn't a request. It was a command, delivered on camera, broadcast to every news outlet in Savannah and 3 counties beyond. Caldwell's Johns Hopkins mentor couldn't help him. His private investigator meant nothing. His board connections were vapor. Pentagon security isn't something a small-town hospital administrator negotiates with. He was escorted past staff who wouldn't meet his eyes, past Martinez who stood at attention as he passed, past the young soldier who looked at him the way you look at something that crawled out from under a rock. Hannah stood in her civilian clothes, the tarnished challenge coin pressing against her thigh in her pocket, and watched a man's entire life structure dismantle in 4 minutes flat. The John Doe was wheeled out of the elevator, the Army Ranger, conscious now, pale but alive, his eyes finding hers across the crowd. She'd saved him in Fallujah when the Humvee caught fire. She'd saved him again 3 nights ago when the pericardiocentesis needle went in at the exact correct angle, at exactly the correct depth, with exactly the right pressure. He looked at her, and something in his expression shifted, recognition not just of her medical skill, but of who she'd been hiding all along. The general approached her. Not formally. Not for cameras. A 2-star general walking across a hospital lobby to speak to a Master Chief Petty Officer like an equal. The John Doe's workup came back negative for biological exposure. Your mission parameters are satisfied. You have a posting at Naval Medical Center San Diego. They're expecting you Monday. Hannah nodded. Yes, sir. Also, the general continued, his voice dropping, you may want to know that Dr. Caldwell's network just collapsed. His mentor at Hopkins distanced himself within 20 minutes. The private investigator dropped his contract. The board chairman is considering early retirement. Institutional power doesn't protect you when you pick a fight with the Pentagon. She didn't smile. But her shoulders, which had been curved inward for 3 years, straightened. The veteran approached and shook her hand. The young soldier, she recognized him now, a junior enlisted from Charlie Platoon, nodded with the specific respect that comes from knowing someone who's paid the cost. The hospital administrator asked if she'd consider staying, training the emergency staff, bringing her expertise to Cedar Creek permanent. The general shook his head before Hannah could answer. Master Chief Clarke has a posting. She's trained enough people. Hannah collected her security badge from the locker room. Martinez offered it to her with both hands. She took it and pressed her palm against his shoulder. No words needed. Just the specific gesture of warriors acknowledging what had been endured in silence. 6 months later, someone sent Hannah a photograph, Dr. Caldwell in a community college classroom, teaching CPR to bored teenagers, his face gray and defeated, making $12 an hour. She studied it for 30 seconds, then filed it away with the same composure she brought to everything, no satisfaction, no revenge, just acknowledgement that some costs are paid in full. The tarnished challenge coin sat on her desk at Naval Medical Center San Diego, where she now trained the next generation of combat medics. Not just how to save lives. How to make impossible choices when missions and morality collide. When the right thing and the ordered thing point in different directions. When your hands remember their training better than your mind remembers your orders. The Army Ranger she'd saved, twice, messaged her every few months. The grizzled veteran sent terrible jokes. Cedar Creek Medical now had a combat medicine training program funded by Pentagon grant, and 3 former military medics on staff. Hannah sometimes thought about the diner at 3 a.m., the cold coffee, the moment she thought 3 years of cover had been wasted. But the Ranger was alive. Caldwell's network couldn't protect him from his own cruelty. And the mission, monitoring for biological exposure that proved negative, succeeded despite the cost. She taught a class of 20 new medics the proper angle for pericardiocentesis, her hand steady, her voice certain. One student asked how she stayed calm under pressure. Hannah picked up the tarnished challenge coin, turned it once between her fingers, and set it back down. True class, she said, is what you do when the lights go out. The students wrote it down, not understanding yet that some of them would learn the meaning in burning vehicles and collapsing patients and missions that demand silence. Hannah knew. She'd already paid that cost. And she'd pay it again. If you've made it this far, you already know the truth. Heroes walk among us, and they're often the quietest ones in the room. Subscribe for more stories about the people nobody was watching until it was too late for the people who disrespected them. Like this video. Comment below, have you ever been underestimated by someone who had no idea who you really were? And hit that notification bell so you don't miss the next story.